Our next speaker is Anna Paulsson. Anna trained undergraduate at Smith and UCLA. She went to medical school and her internship at Wake Forest, and then did her rad-onc residency and fellowship at UCSF. She's going to talk, I'm not going to make a joke about, or try to make her introduction humorous, because I thought her title was fairly interesting. No, you won't become the Hulk if you come see me. So this is Anna Paulsson, please.
So yeah, my title is based on a frequent question I get when patients ask me about the side effects for radiation. So I joined St. Joseph Heritage Healthcare this past August in 2018 after completing my residency at UC San Francisco. There's another one. Well, maybe this will work. Oh. And I don't have any disclosures. So during this talk, we will focus on some of the more pertinent long-term side effects of radiation therapy for breast cancer, prostate cancer, and head and neck cancer. And then we'll change topics slightly to introduce a modality of radiation therapy, which is new to Sonoma County, and the potential impact for our patients. So cancer patients today are living longer, and overall survival has improved. And this is due in part to significant advances in cancer therapy. In particular, targeted therapies that includes radiation treatment. So breast cancer and prostate cancer are the most common cancers in women and men. And overall, these cancers have excellent 10-year overall survival rates. And even patients with metastatic disease have 5 years survival rates of approximately 30%. This means we have to very carefully consider the long-term toxicity of the treatments that we provide. And as patients live longer, their care is becoming increasingly complex. In addition to a cancer diagnosis, patients have an increasing number of medical comorbidities, complex psychosocial needs, the desire to maintain a good quality of life, and the increasing financial burden of multiple treatments. Cancer patients also have similar rates of obesity, physical inactivity, and tobacco use, which more significantly impact their overall health when combined with a cancer diagnosis. So breast cancer is one of the most common malignancies we treat with radiation therapy, and there are several potential long-term side effects that warrant discussion. The standard course of radiotherapy for breast cancer involves 4 to 6 weeks of daily treatment directed at the breast and potentially the surrounding lymph nodes. Depending on the risk of recurrence and the patient's molecular markers, patients may also have adjuvant endocrine therapy and/or chemotherapy as part of their treatment. Short-term side effects of radiation include erythema, fatigue, dry and moist desquamation, and accompanying soreness and edema. The best way to combat the acute fatigue is exercise. So, and although it may be harder to get out the door as they reach the end of radiation treatment, I do encourage them to at least start with a 10-minute walk twice a day if it's safe for them to do so. The long-term side effects of radiation include tissue fibrosis, edema, telangiectasias, complications related to breast reconstruction, edema or lymphedema, brittle ribs, brachial plexopathy, pneumonitis, and radiation-induced cardiac toxicity. The adjuvant endocrine therapy also has side effects, which commonly include decreased libido, hot flashes, arthralgias, fatigue, weight gain, and an increased risk for osteopenia and osteoporosis. One side effect which is of frequent patient concern is the cardiac toxicity associated with radiation treatment. Radiation-induced heart disease manifests at least 10 years after treatment as coronary artery disease or atherosclerosis. Radiation does not increase the risk for congestive heart failure, arrhythmias, or valvular disease. Older studies performed prior to using modern radiation techniques indicated that radiation therapy contributes to increased cardiac mortality. Unfortunately, that is the most widely circulated information and generates a lot of fear for patients. The reality is that the cardiac risk is much lower than these older studies indicate. Modern radiotherapy techniques are much more elegant and significantly limit the radiation dose to the heart. Ultimately, the dose is dependent on the patient anatomy and if the surrounding lymph nodes are treated. More contemporary studies indicate that the absolute risk of radiation-induced cardiac disorders is very small. It is difficult, however, to assess the risk for some of our younger patients. Given that radiation-induced cardiac disease is a late side effect, longer-term follow-up is warranted for the younger women treated with radiation to adequately quantify their risk. And so this is an example of a breast radiation plan. The purple line represents the 50% isodose line, which is 50% of our prescription dose. And the mean heart dose from this radiation plan was 77 centigrade. And I'll provide some more context for what that means. So how does our experience at St. Joseph compare to other local centers and multinational institutions with regard to the average heart dose? At a mean dose of 105 centigrade, we have a lower mean heart dose than which was published in UCSF in 2016, and a lower heart dose than the multi-institutional meta-analysis that was recently published as well. The Darby study in the last line of this table is an older study, so that may reflect why the mean heart dose is much higher. So our mean heart dose of 105 centigrade clinically translates to a very small absolute difference in cardiac risk. So using the data published from Darby et al. In the New England Journal of Medicine, we can extrapolate that our mean heart dose of 105 centigrade increases the risk of acute coronary syndrome from 4.5% to 4.8%, or a 0.3% absolute difference for a healthy woman who's 50 years old without any pre-existing cardiac risk factors. Patients with pre-existing cardiac disease may be at an elevated risk compared to those without. So based on the above figure taken from the Darby publication, a mean dose of 105 centigrade, or 1 gray, a patient would have at least one cardiac risk factor, would have approximately a 3 to 4% cumulative increased risk of death from ischemic heart disease, and a 7 to 8% increased cumulative risk of at least one acute coronary event by age 80. And so although the risk of radiation-induced cardiac disease in healthy patients is very low, how do we reduce the risk for patients with pre-existing heart disease that we know have some increased risk? It is important to continue to work on modifying risk factors with this group of patients, such as increasing exercise, both cardiovascular and weight-bearing, limiting alcohol intake, smoking cessation, and consuming a plant-based diet. Current exercise recommendations include 4 to 5 hours of aerobic exercise per week, 2 sessions of strength exercise per week. It is also becoming increasingly difficult to counsel patients regarding food choices due to the overwhelming amount of nutrition information available today and the preponderance of cancer-fighting diets. What we do have strong evidence for, however, is that a Mediterranean diet has a protective effect, and there's also evidence suggesting that a Western diet with high processed food intake is associated with higher all-cause mortality. So general principles of the Mediterranean diet include mostly plants, high fiber, limiting the amount of red meat, healthy fats such as olive oil, and moderate red wine intake. For patients who are interested, we are offering a quarterly nutrition class at the Round Barn Cancer Center. This was just started in March. Our first course was on March 22nd. It was well attended. And we have 3 more dates for this year, June 21st, September 20th, and December 13th. Next, we are going to turn to prostate cancer to discuss some of the key points regarding long-term toxicity for men treated with radiotherapy, with and without androgen deprivation therapy. For patients with low-risk prostate cancer, multiple radiation options are available to them, including radiation alone to the prostate and seminal vesicles or brachytherapy. So brachytherapy is an internal type of radiation that can be done in the form of permanent seeds, which are left in the patient and do pose a risk of radiation exposure to friends and family members. Or brachytherapy can be done as a temporary implant. The temporary implant, the seeds are removed at the time of the procedure, and so there's no risk of radiation exposure to friends or family members. The duration of risk does depend on the half-life of the radioactive seed that is used, but typically the recommendation is to limit exposure to pregnant women and small children for about 2 months. Radiation therapy for intermediate-risk prostate cancer may include treatment to the pelvic lymph nodes if the risk of nodal metastases is considered high enough. These patients often receive 4 to 6 months of androgen deprivation therapy, also known as ADT. Patients with high-risk prostate cancer almost always involves treatment to the pelvic lymph nodes and necessitates a longer duration of hormone therapy. Up to 2 years of ADT is recommended for this group of patients. And the data to support the survival benefit of ADT does use 2 years of ADT. However, given the risks I will outline in the next couple of slides, sometimes the full 2 years is not recommended. Side effects of radiotherapy for prostate cancer include short-term side effects such as urinary frequency, urgency, increased urination, nocturia, dysuria, urinary retention, diarrhea, rectal irritation and pain, hemorrhoidal irritation, and fatigue. Long-term side effects include the risk of a urinary stricture, rectal bleeding from telangiectasias, increased risk of healing problems in the rectum and the bowel, decreased volume of ejaculate or dry ejaculate, and persistent urinary frequency and nocturia. In addition to the radiotherapy side effects, the androgen deprivation therapy also has side effects, which include hot flashes, decreased libido, fatigue, weight gain, decreased muscle mass, liver enzyme abnormalities, osteopenia and osteoporosis, mood changes, and metabolic syndrome. One of the most challenging aspects of managing prostate cancer is the androgen deprivation therapy. Weight management can become increasingly difficult as ADT decreases lean body mass, increases adipose tissue, and these subsequent body composition changes can increase the risk for diabetes and metabolic syndrome. And the excess risk of diabetes and metabolic syndrome associated with ADT is thought to be upwards of 60%. For this reason, exercise, to include strength training, is critically important for these patients. The same nutrition and exercise guidelines apply for men on androgen deprivation therapy as I was previously discussing. Weight-bearing exercise twice a week, 4 to 5 hours of aerobic exercise per week, and a Mediterranean plant-based diet. Additionally, due to the increased risk of osteopenia and osteoporosis associated with ADT, we do recommend a calcium and vitamin D supplement for these patients. Radiation therapy also has long-term side effects that are worth noting, particularly when the pelvic lymph nodes are included within the radiation field. Chronic radiation changes begin to appear 6 to 12 months after therapy is completed, and the bowel epithelium is particularly sensitive to these changes due to the high cellular turnover rate. Radiation causes fibrosis in small arteries and arterioles that can lead to healing problems and increased risk of complications after bowel or pelvic procedures. So for men with a history of prostate cancer treated with radiation, it would be important to review with their treating radiation oncologist the limits of the radiation field prior to any invasive procedure that would involve a biopsy or surgery within the pelvis to adequately counsel the patient on the risk of potential healing problems. The last cancer subtype I will specifically address is head and neck cancer, which can have significant long-term sequelae related to treatment. The standard course of treatment is 6 to 7 weeks of radiation treatment directed at the primary cancer and the at-risk lymph nodes. This radiation is often combined with concurrent chemotherapy. The patients are immobilized in the mask shown during treatment, and long-term side effects of radiation can be significant as patients with HPV-positive disease without a significant smoking history are often cured of their cancer, even if they have lymph nodes involved at diagnosis. Side effects include mucositis, dermatitis, xerostomia, weight loss, dehydration, and fatigue. We aim to not prophylactically place feeding tubes in these patients, though sometimes it is necessary to maintain adequate nutrition throughout treatment. Late side effects of head and neck radiotherapy include soft tissue fibrosis, trismus, xerostomia, hearing loss, vasculopathy, osteoradionecrosis, hypothyroidism, dental caries, hyperpigmentation of the skin, swallowing dysfunction, taste alterations, chronic aspiration, and potentially voice changes. So although among the long-term side effects of the risk to dental health is particularly notable. Xerostomia and salivary gland dysfunction increase the risk of cavities and ongoing oral hygiene complications. This is due to the fact that radiation therapy alters the composition of saliva by decreasing its viscosity, decreasing the buffering capacity, and thus altering the oral cavity microflora. This causes the dentin and the enamel of the teeth to dissolve more easily and impairs remineralization of the dental hard tissues. Meticulous oral hygiene is essential to preventing ongoing problems with oral health. Recommendations include brushing 2 to 4 times daily, daily flossing, and use of a water pick. We also often recommend prescription toothpaste that contains fluoride, and the frequency of routine dental visits is increased to 4 times a year from twice yearly. Dental extractions or procedures that involve drilling into the bone should absolutely be avoided in these patients due to the risk of osteoradionecrosis and poor wound healing. For this reason, we usually have patients have teeth extracted before they start radiation treatment to prevent the need for for dental extractions after treatment. However, some patients do need surgical dental procedures after completing radiation therapy to the head and neck, and this is another instance where it's critically important to review the radiation field and the radiation dose to the jaw with the treating radiation oncologist. As clinicians, we also have to be aware of the long-term sequelae of treatment side effects that extend far beyond physical side effects of treatment. The PDF indicated on this slide is an excellent resource for clinicians transitioning over to a survivorship model of care for the individual patient. This report characterizes the trends in cancer incidence and mortality, reviews long-term consequences of cancer and treatment for cancer, and defines optimal care for cancer survivors. This PDF is not limited to just physical health, but also includes information regarding financial burden, economic and employment issues relevant to cancer survivors, and challenges that they may face with health insurance as a cancer survivor. There's also a really nice figure in Chapter 3 that summarizes the late side effects of surgery, radiation therapy, and chemotherapy by cancer subsite. So I'd now like to change gears slightly to discuss new technology in radiotherapy that is available at St. Joseph Healthcare in Sonoma County. So stereotactic body radiation therapy is also known as stereotactic ablative radiation therapy, is highly conformal radiation treatment that is delivered in up to 5 treatments. It can be delivered via a linear accelerator, which is what we have here, or on a CyberKnife accelerator. And one modality is not necessarily superior to another. Many of you may have heard of gamma knife radiation treatment. It's a trade name for a type of radiation used for intracranial metastases. And SBRT is similar to that, but is not limited to the brain. SBRT uses higher doses of radiation therapy delivered with a steep dose gradient to spare the surrounding tissues. To safely deliver this treatment, our biggest challenges are patient immobilization and motion management. For example, a lung tumor that is moving while the patient is breathing throughout treatment. So one of the most common ways SBRT is used is for early stage lung cancers and lung metastases in patients who are not surgical candidates. SBRT offers these patients really good local control, about 90% at 3 years. And it doesn't have any of the potential complications that surgery may have. However, for patients who are surgical candidates, surgical resection is still the preferred recommendation of treatment as these patients are able to have their mediastinal lymph nodes sampled. Lymph node sampling can detect occult metastatic disease that is below the sensitivity of a PET scan. So this is a sample lung SBRT plan for a patient who has a primary lung cancer that is relatively close to the heart. The red line in the center is the full dose prescription, and the purple line that abuts into the heart is the 50% of the radiation prescription. With our steep dose gradients, we are able to accomplish a 50% fall-off dose in 1 centimeter, which is critical for treatment and patient safety. SBRT also has multiple areas of use outside of the lung, which include spine and liver metastases, patients with oligometastatic disease, or a single site of progressive cancer in an otherwise controlled primary, and lesions in the kidney and adrenal glands. Depending on the site and the patient's anatomy, lesions outside of the lung frequently require fiducial placement with our interventional radiology colleagues so that we can track the potential movement of the tumor during treatment. So I'd like to thank you for your attention, and if you have any additional questions or concerns, I'd be happy to address them, or you can reach me at my email that is listed.
Not only fibrosis, but capillary damage. So radiated tissue may have 30% of the normal capillary density of unradiated tissue. For patients, particularly with prostate cancer, early initiation of hyperbaric oxygen therapy can be 95% effective if therapy is started within 6 months of onset of bleeding. Otherwise, it's 60 to 70% effective. Same is true for radiation to the mandible, where the risk of infection and wound breakdown is almost 10 times as high if they're not pre-treated before dental procedures.
Thank you.
For breast radiation and risk of CAD, does it matter left breast versus right breast?
Right breasts receive, or if the right breast is treated, almost no radiation dose to the heart. So that cardiac toxicity is particularly for left breast radiation. Because the right breast we're able to have the dose fall off really steeply, the dose that the heart receives with right breast radiation is limited maybe only to scatter, so very, very minimal.
And is the CAD from radiation, is that inflammation fibrosis or is it atherosclerosis?
It's atherosclerosis.
So do you suggest a statin for these ladies?
No, not necessarily.
I have a question about the IMRT. Can you define this intensity modulation, whether it has limited side effects as compared to traditional?
So IMRT, the advantage of IMRT is that we're able to spare the surrounding normal tissues for the higher radiation doses. For example, for prostate cancer, we frequently use, in older radiation treatments, we used multiple static fields, and so the dose gradient wasn't as steep. For IMRT, we're able to sculpt the radiation dose much more elegantly. But the downside of IMRT is it can increase the scatter dose because we're using more beams or arc therapy, where the radiation comes in as an arc. So the low dose radiation is actually increased for IMRT, but the high dose radiation is better sculpted.
I have a question.
Yeah.
We used to see many people who had mantle radiation as a treatment for their lymphoma, and they had terrible both carotid and have terrible carotid disease and coronary disease. How is that dealt with now? Is that still used, or are you doing it in a different way?
So for lymphoma, we're more frequently doing involved nodal radiation or involved, which only has treatment of the lymph nodes that had lymphoma to begin with. So we're not doing large fields where we treat the entire nodal chains that go from the supraclavicular all the way into the mediastinum. We're treating the PET positive nodes that were PET positive at the time of diagnosis. So much, much smaller radiation fields.
So we should see less of that particular disease process.
Yes.
And just a comment, the vascular atherosclerosis that we see in post-radiation is way more complex than the typical atherosclerosis. The lesions are generally more diffuse and much harder just in terms of the density of the plaque and the plaque burden.
And for that reason, especially for patients who have head and neck radiotherapy, we do recommend a carotid duplex about 5 years out after treatment just for surveillance.
Okay. Thank you very much.
Thanks.